The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our January 13 Safe and Calm webinar. We're happy to report that vaccinations seem to be continuing at our member facilities and other facilities. And additionally, HHS has decided to release the doses of vaccines that were currently being held for second doses. And we do know that other vaccines are close to clinical testing and approval as well. So perhaps we're seeing at least a glimmer of light at the end of this very long tunnel. This morning, we have a few updates for you with a focus on recent CDC guidance on confirmatory testing. In fact, this is the CDC's third iteration of this guidance, and it's its third flowchart as well about when to conduct a follow-up confirmatory test. We have a very short update for nursing homes at the end of the program. And this morning we will start as usual with a brief legislative update from Dalton, our Director for Public Policy.
Good morning, everyone. I just wanted to touch on a couple things today, just some things for you to know. As the legislature's first day of session is today, at noon, they start at noon. I just wanted to post the first 6 months of the new legislative calendar so you can kind of be aware of their work schedule and kind of the flow of information here in Lansing, and well, at least the public information. As you can see, today is the first day of session. We anticipate it to be rather light on actual items since it is the first day, and they'll hit the ground running next week. Another thing to note, if you've read the newsletter, or I think we sent it out over the listserv, there have been delays for some of the direct care worker payment reimbursements. We've been told that it was due to some key staff transitions at the state and delays in getting temporary staff and approval for those staff. We have heard from members that November and December reimbursement payments have been specifically infected, but MDHHS does plan to have all the payments out by the end of January, and it's our understanding that they've been working through these pretty diligently. And then just another thing, if you've been kind of following what's been going on at the national level, second draw for PPP loans is going on. A organization can receive up to $2 million if they meet the eligibility criteria. This does include not-for-profit aging services providers, and that up to $2 million is up to $2 million or a maximum of 2.5 times payroll. And then providers are eligible if they have 300 or fewer employees, have or will use the initial amount of PPP loan dollars they took, and can demonstrate a reduction in gross receipts from 2019 to 2020 of 25% or more, then your organization would be eligible for a second shot at the PPP loan program. It's our understanding that the application portal is to open sometime this week. As of last night, it was not open. I haven't checked this morning, but I did link a sample application to this slide so that you can see what kind of information will need to be submitted. And then for more specific information, you can check out a link there to a summary that Leading Age National did on the program. I think it's actually pretty well written and kind of explains some of the more intimate mechanics of the program that would just be a little overkill for this morning's webinar. A couple changes here on the important date slide. This week, I did note that the second draw PPP web submission portal is going to open. It is also important to note that we have heard that the week of the 24th will be the next distribution for the third round of PRF funds. Initially, HHS wanted those all to be done before the end of January, but now we're hearing that some of those funds will still be distributed in February, but the next batch of them will be coming out the week of the 24th. So if you have not received your phase 3 PRF funds, you may be getting it the week of the 24th. And then we have a couple of deadlines on here that have been on here, including the extension of the $200 enhanced CRC payments and the end of the direct care worker wage pass-through program being extended to the 28th of February.
Okay, thank you very much, Dalton. It does look like we have one question. One item I have heard in the calculation for the 25% revenue drop for PPP loans, you would need to include provider relief funding and revenue for 2020 revenue amounts.
Thank you. That's good to know.
Okay. Other than that, we do not have anything else, so we can go ahead and move on.
Okay, thank you, Dalton, and thank you, Blake. We're going to take a few minutes this morning, as usual, to look at the Michigan numbers, which are at least holding fairly steady in general, with just a slight maybe trend upward in some areas. So last week, we reported a slight rise in overall caseload after a sharp decline since things peaked significantly in November. And at this point, even though things go up and down a little bit, that rise, the recent rise, appears to have at least leveled off. We also had a little bit of a sharp incline in the number of daily deaths since that significant decrease from November. These numbers do still seem to be quite high. They do fluctuate day to day. And you can see there has continued to be a rise in these numbers since last week. But we also know that while these deaths are generally related to the amount and numbers of positive caseload, there's also some lag time before the number of deaths may start to go down. So we're hoping to see further declines in caseload in the near future. The CMS published county transmission rates for Michigan were improving through December, as you can see on the slide, with many counties moving out of the red category. Overall, the numbers still seem to be stabilizing a bit after the surge in November, but there was also a shift toward a few more red categories as of January 6th. So the other issue is that there's only one Michigan county listed at this point that is not level E, and it, of course, is in the Upper Peninsula. New cases in skilled nursing facilities have continued to stabilize since the end of December, with only a slight increase in cases during the past week, but overall very stable. New cases in homes for the aged definitely decreased as well since the end of December. And the same is true for new cases in adult foster care. So hopefully all these trends will continue, and with sharp decreases now that residents and staff are being vaccinated. These are all the numbers for long-term care residential settings published by MDHHS last Monday. And you can see that the total cases over time for staff and residents is nearing 40,000 over the entire course of the pandemic, and over 6,100 deaths. So we'll move on now to our general updates, and we will start with a focus on recent CDC guidance on testing. But first, we want to note that, again, the state of public emergency has been extended to April 21st. When CMS and HHS announced this, they noted also that it extends the use of the 1135 blanket waivers. And CMS issued a new tool for applying for a blanket waiver, which caused some confusion to some organizations because the toolkit is not about the large nationwide blanket waivers. The toolkit is for individual facility and state waivers. So if someone wanted to apply for a waiver, they could as an individual facility or organization or health system. And the state also can apply for waivers in and of themselves. But this toolkit has nothing to do with the general waivers that we've been working from that allow a lot of flexibilities in serving residents. So these blanket waivers were last updated on December 1, And the link to that webpage, for those of you who might want to review it, is in the center of the slide. So last week, the CDC issued updates to considerations for the use of antigen tests in long-term care facilities. These updates are in alignment with recent discussions about antigen tests and the problem of false positives. The guidance also notes that while technically this is titled for nursing facilities, it applies to other long-term care residential settings as well. So the CDC has identified that there have been a lot of false positives using antigen testing, but they also noted that many of these inaccurate findings are most likely due to failure to adequately follow the test instructions. And that's especially true when you get a lot of positive tests in lower risk situations, such as no outbreak or lower community transmission. Additionally, CMS and CDC notes that there's limited data on the use of tests in asymptomatic populations. And as before, the PCR test is still considered the gold standard, but it's also not thought to be very helpful because of the time lag mostly. The CDC still supports using antigen tests for rapid screening in long-term care facilities, even though they are a bit less accurate, especially when used in asymptomatic persons. So the likelihood of a false negative is still higher than a false positive, but either can happen in antigen testing. And thus all antigen tests that are negative should be considered tentative or presumptive. The first guidance that was put out when antigen tests first were being used for screening and other purposes in nursing homes, that first guidance provided a rather clear decision tree for interpreting the antigen test results and identifying when a confirmatory test would be needed. In the second and this third guidance, there's more focus on the clinician and reviewing the entire scenario to determine when to test, how to respond to the findings of both the initial and the confirmatory test. Much of the information in this guidance supports earlier recommendations, but definitely it focuses more on the overall conditions and the scenarios when the tests are being done. So clinicians must understand the overall test sensitivity or accuracy when interpreting the test. Current antigen tests in common use right now provide between 84 to 97% accuracy. But it's important to remember that those numbers only apply if the test has been conducted within 5 days of symptoms. So it's less clear what accuracy would be for asymptomatic persons. Clinicians must also consider the test results based on the overall scenario, whether or not there were any symptoms, whether or not there were recent exposures, or if there were currently any active cases in the facility and or high prevalence in the surrounding local community. So all of those things are factors that clinicians have to think about when deciding if a confirmatory test is needed or how to treat the person as well. So this updated guidance provides a set of reminders about overall use of antigen tests, particularly for screening purposes, which we all know we use these tests for quite a bit. The tests are more likely to produce false positives than false negatives. I'm sorry, I said that wrong. The tests are more likely to produce false negatives than false positives. So staff and residents must continue to be tested over time when there is an outbreak in the facility, with the idea that false negative cases would be identified in follow-up testing. So the likelihood of false negatives when the entire facility has tested negative for 14 days is very small, which is why you have to continue to do that. One of the many reasons you have to do that. That also has to do with the incubation period. The potential for false negatives is also one of the reasons that residents should be placed on transmission-based precautions as needed through the outbreak. So staff with known exposures in general can continue to work based on the kind of close contact they may have had. And there is CDC guidance on the kind of contacts that would preclude working. And the link to that is in the fourth bullet or the center of the slide there. An important point that CDC finally put some clarification in their guidance are the concerns about an earlier guidance that provided an option that decreases the quarantine time for persons who had been exposed to the virus. These options are not the preferred option or a recommendation for staff or residents of long-term care settings. So even though Michigan approved this option in general, they did not approve it. MDHHS did not approve it for use in nursing homes. And we had received quite a few questions about that. So at this point, those reduced time for quarantine after exposures do not apply to staff or residents in long-term care facilities. Antigen tests in general should not be used to determine the duration of precautions for residents or staff in nursing homes. That still holds. And in fact, test-based strategies are still discouraged overall. So the revised algorithm or flowchart starts with symptomatic persons. If a resident or staff person is symptomatic and tests positive, no confirmatory testing is needed and persons must be treated as positive. This, of course, will trigger an outbreak response when there are no current cases in the facilities. But clinicians can consider even these positive tests as perhaps needing a follow-up when it appears that it might be an unusual or inaccurate finding. If there were many positives found on that day of testing, or any other factor that could appear to relate to inappropriate specimen collection or processing, you might consider doing some PCR confirmatory testing. And that's also true when a person resides in a facility with no cases and no exposures and perhaps develops some non-respiratory symptoms following a vaccine administration. So the CDC has put into its guidance some issues related to symptoms following vaccines while you're doing ongoing testing. That could trigger some additional testing. So you need to look at the whole scenario, the clinician does, when deciding how to think about the results. So that was for symptomatic persons only who test positive. For symptomatic persons who test negative, in general, you should confirm the test immediately using a PCR test. And during the interim, you must treat the person, of course, as positive. Clinicians can decide to forego confirmatory testing if there is really a low likelihood that the person is COVID positive, even if they have some symptoms. And this also applies to the same scenario we just talked about when the symptoms are non-respiratory, follow vaccination, and the person is in a very low risk non-exposure setting. So you have to look at all of the factors in order to determine how to think about these tests. If the person, though, did have symptoms and also experienced a close contact, even if both tests are negative, if the antigen test and the confirmatory tests are negative, but the person had symptoms and a close contact, that person should remain in transmission-based precautions for 14 days. And remember, again, the option to reduce quarantine time for these exposures are not appropriate for long-term settings. So we're talking about a full 14 days here. Staff should be excluded from work and return according to the policies. And we provide a link a couple times in this webinar to those risk assessment policies for staff. It depends on the context of staff exposure to determine whether or not they should be working or not. Persons who develop symptoms within 90 days, again, of the COVID infection should be assessed for alternate diagnoses before testing. But again, the amount of outbreak and the community transmission should be considered here as well. You can move forward, Blake. So those are the recommendations for persons with symptoms. This next section is for persons without symptoms who were tested as part of an outbreak response or following a close exposure. So this doesn't have to do with your serial testing yet. These are the rules just for persons with symptoms. Without symptoms, forgive me. Persons without symptoms who were tested as part of an outbreak. So there's some transmission risk there. If the antigen test is positive, person has no symptoms, but they come back positive, it should be confirmed with a PCR test. And until confirmed, of course, they should be treated as positive. When the possibility of being COVID positive is high, in other words, you have a major outbreak in your facility, or maybe the person's roommate tested positive, clinicians can consider simply not doing the confirmatory test and treating the person as positive. If the confirmatory test is positive, of course, you must transfer the person to the COVID unit. For persons who are asymptomatic and have a negative antigen test, or even if they had an antigen test that was positive and the PCR test follow-up was negative, your action should really be based on what the current conditions are. If it's an outbreak, place on precautions as needed related to your outbreak plan and continue your serial testing. If in this scenario there is a known close contact, person is asymptomatic and was negative, or person was asymptomatic, was negative, and then positive, forgive me, this is so complicated, I need to make sure I get my words right. So if a person who had a known close contact was asymptomatic and had an original negative test, or had an antigen test that was positive but the follow-up was negative, you should still put them in close quarantine for 14 days. And if it's a staff person, again, you should use the risk recommendations we referenced earlier. And again, that is at the bottom of this slide as well. Remember that all of the recommendations on this page are to be used when there is an outbreak or significant exposures and the resident or staff person is at least at first asymptomatic. The last category is about asymptomatic persons when there has been no outbreak. So this would include times when you have to do serial testing for staff, when there is perhaps some local transmission but no current cases in the facility. So the likelihood of a positive is small, and if someone tests positive, you should go ahead and do the confirmatory testing. Until you receive the confirmatory test result, you should treat the person as positive. If the PCR follow-up test is negative and there have been no exposures and no other cases in the facility for at least 14 days, you can consider this a false positive. Obviously, no actions are needed for any staff who are asymptomatic and have a negative antigen test. So here's the latest flow chart for determining when to do confirmatory testing. PCR testing is referred to as NAAT on the chart, and antigen tested is abbreviated AG. If you get disagreeing results between the two types of tests, you can always consult with the local health department about that if you need some assistance in thinking about how to interpret it. And remember that the basic rule is still about the likelihood of being positive or negative. So asymptomatic persons may not need a confirmatory test when they test positive if they're in a high-risk situation, and symptomatic persons testing positive can be retested and using a confirmatory test if there's a low likelihood. So a few reminders about outbreak responses. Residents who were known on admission to be COVID positive and any new admission who tests positive within 14 days of admission, this is just a reminder that they're not considered facility-acquired cases. They do not trigger an outbreak response. The testing guidance was, this was referred to in the testing guidance that were updated, and it's also included if you need to look at the details of this at the link at the bottom of the slide. So the CDC updated several of its guidance over the last week, and they're mostly all related. It's specific testing guidance for nursing homes, which is in the link at the bottom of this page, was updated. But there was little new information. We did include it here just to discuss a couple important points. Basically, as soon as you have an outbreak, you should plan and expect to find others immediately. Those facilities who test rapidly and act rapidly generally have a better outcome in terms of spread. Also, consider testing everyone in your facility, staff and residents, every 3 days for the first 2 weeks to find those new cases quickly. You can then move to weekly testing until the infection has been cleared from the facility. The guidance does note that if tests are limited, facilities should focus on those who may have had closer contacts with the infected persons. But most importantly, in this guidance, and I want to focus on this a bit, there is a paragraph that provides an option to use a test-based strategy to discontinue transmission-based precautions. And in general, it is not recommended. So the CDC is allowing this, but CMS does not allow it. And the state, MDHHS, definitely does not approve of this option. So especially for people in quarantine, those are persons that there are some options to discontinue that quarantine before 14 days. And there's a couple different ways you can do that, and one of them includes a test. However, again, MDHHS does not approve of the option and has made that clear to us in several conversations. So we're going to pause for a few questions, and I apologize. I know this is very complicated. It's complicated for me too. I had to think through it a few times. But let's take some questions and see where we can go.
All right. Thank you very much, Deanna. Excuse me. Before we get into any questions, I just wanted to give everybody a reminder. If you did miss our finance and strategy, the very first part of the series on January 7th, there is no issue at all. Feel free to come and join us as we open day 2 of our finance and strategy event this upcoming Thursday, January 21st, with our friends from Ziegler and panel discussions by Leading Age Michigan members. This half-day session will focus on strategic trends in the senior living and care sector with a framework of the national economy, the capital lending environment, and aging services climate nationally in the state of Michigan. So you can go ahead and just head over to leadingagemi.org. You can go ahead and click on the events tab, and that will bring up our events calendar with everything coming up. Finance and Strategy Day, I'm assuming, should be the first or second event right up there. So you can go ahead and register for the 21st. If you missed the first day, it's no worry. You can still go ahead and join us. And we also do have a couple other series that were just opened up for registration. It's 2 separate series, and they are both 12 parts, basically one a month for the rest of the year. So those are something I would definitely go check out, with a lot of great information coming soon. So let me get to the questions now. I recommend checking the MDHHS LTC reporting site to confirm your numbers. We noticed a significant error in our numbers that did not match our reporting and had to have it corrected. Please check that site to be sure your numbers are as you report them.
So thank you for that. Now, I just want to confirm that you're talking about the individual facility level numbers as they're being reported on the MDHHS site.
Yes.
Right, okay.
I spoke with KCHD about removing a positive that had a negative PCR within 24 hours from our cumulative data, awaiting response from IPRAT team.
Okay, good. I do think that when you have some discordant results, in other words, results that don't align between the antigen test and the PCR test, and it looks like you might have a false positive, that you do contact your local health department and discuss it with them as well. Technically, you're supposed to report false findings to the CDC as well, and they can help you talk through that.
Okay. The CDC also put out guidance for staff with post-vaccine symptoms and antigen testing to get them back to work and not have to keep them off at 10 days. Same for residents and isolation guidelines.
Right. Thank you.
We had staff previously test negative on AG with 2 negative NAATs, but we consider them as positive still based on our prior guidance. We have not included them in weekly testing since it has not been 90 days. Now with the new guidance, should we re-include them in weekly testing? So in other words, with the updated guidance, they would be considered false positives previously.
Okay, can you just reread the first part of that, Blake, that tells me what the tests were?
So we had staff previously test positive on an antigen with 2 negative NAAT, but we considered them as positive still based on prior guidance.
Well, first of all, I would consider how old those cases were, that case is, before I would do anything about it. I think that if they were very recent, then I would reconsider that. If they were long ago, I would not. I would just let it all go. But considering, and remember that you still have to look at the whole scenario. So were they positive antigen tests with negative follow-up tests when you had an outbreak? What was the timing between the positive antigen and the PCR test? So I would apply the whole scenario. If it was a recent case and it really does look in your scenario that possibly this was a false positive antigen test, I would contact your local health department and talk with them. But otherwise, I would probably let it go.
The person just said October, they are not due for testing again, and February question is to start retesting them before the 90 days.
I think that it would be prudent to start retesting them before the 90 days is up, but I think October is far enough. I mean, I don't think that there's anything else that you would really want to do. If they have a false positive, that is one of the issues. Is that if you identify someone as positive based on antigen test alone, which everybody did in the beginning, you are technically possibly not testing that person again for 90 days, and therefore might not be aware when they do actually get COVID. So that is a challenge. So I would probably start testing them now, see what happens.
Okay. FYI, MDHHS links multiple times to the CDC document about guidance for discontinuing TBP, which includes using a test-based strategy. Where is the MDHHS info on not using the test-based strategy? Also, we have had several false positive PCR tests. We would suggest immediately asking the lab to retest the original swab, not just following up with 2 PCRs, since MDHHS doesn't like to acknowledge false positives.
Okay, let me take the first part of this. I don't think there's anything in writing that says that MDHHS will not allow. Well, there is. If you look at the original guidance from months ago, when the CDC went to a symptom-based strategy rather than a test-based strategy, the MDHHS issued that guidance in alignment with the CDC. However, in conversations with members and individual MDHHS discussions, they've made it clear that using the protocol listed on that CDC guidance to discontinue precautions early is not something that they allow. They have made that clear to us in a couple discussions, but I do not have anything in writing that says that specifically. But I would go back and rely on the fact that while they may link to this entire guidance, they do not approve any test-based strategies for discontinuing precautions. Now, the second part you're going to have to read to me again, Blake. I'm sorry, because I can't hold it in my head.
No, that's fine. The second part was basically just also we have had several false positive PCR tests. We would suggest immediately asking the lab to retest the original swab, not just following up with 2 PCRs, since MDHHS doesn't like to acknowledge false positives.
I would agree. I would think that you should have them retest. And one of the things that we all need to remember is that even though the likelihood of a false positive or negative is higher with an antigen test, it does occur with a PCR test as well. And I think you are right. There is a reluctance on the part of the state to acknowledge a false finding, a false positive. But I do think it's because remember that the epidemiologists at the state have a lot of input here, and they have fear of spread through the facility. So if they're going to err, they're going to try and err on the part of being what they consider careful. There are repercussions to that decision if you do have false positives, but that's the way they do things. So following up a PCR test that you think might be inaccurate is also a good, very good suggestion.
All right, thank you. It looks like that was the last question, so we can go ahead and move forward.
Okay. So, brief vaccine updates. The CDC has issued some reminders about monitoring and tracking individual vaccine responses using their smartphone app. And this slide is just meant to provide some resources and information about that. The links are all through the slide. And that system is called BeSafe. So for your staff or for other people that you might come into contact with who have received the vaccine, this is just an option for them. On Thursday, the department, MDHHS, is sponsoring a webinar for those who are using Walgreens as a pharmacy partner. It is intended for all providers, really, but with a focus on assisting HFAs and AFCs and other assisted living providers in general. The department has noted that SNFs pretty much have all started vaccinating at this point. So it's really meant to assist those slightly more independent settings, some of which may not have started vaccinating yet. I do believe that about a minute before we went on the air, we did finally get the link for this, and we will be sending it out shortly. And even though this is not COVID related, we wanted to be sure that members were aware that Section 202 now has providers now have a notice of funding opportunity. So there is information about the process, links to information overall about the funding, and also to a leading age presentation on this new opportunity. So we just want to make sure that members were aware of this. There is a leading age discussion about it on February 2nd. Lastly, a few notes about QSO 21-08 for nursing homes. This guidance came out a little over a week or so ago, and it updated the Focused Infection Control Survey. There were a lot of red text changes, but most were really just grammatical, moving and changing words. But one thing they did seem to add was they talked about the type of screening processes that would meet their criteria for staff, residents, and visitors who are entering the facility. The language seemed a little confusing to me, but it seems that the intention is to allow self-monitoring systems. And we know from previous guidance from CMS that they allow kiosk-type electronic systems as well in order to do the screening. You just simply have to make sure that you are covering all of the aspects and all of the issues, symptoms, potential exposures, temperature, etc., in terms of the screening. And also, lastly, we don't have a slide for this, but on Monday, an epidemic order was issued that updates the guidance for nursing home surveyor testing. It changed the test requirements to weekly for nursing home surveyors going to nursing homes. Laura may be doing some of these tests themselves, and they have attached to that guidance a certification letter for persons to show nursing homes as they come in that they have tested negative and have no symptoms. It's kind of like an attestation. We will be sending links about this and more information in this afternoon's update. So are there any other final questions?
All right, it looks like we have one right now. Are facilities permitting family members who are not guardians or patient advocates, DPOAs, to consent to vaccination for incompetent residents? In the past, surveyors have cited facilities that allowed non-guardian / non-DPOA family members to consent to treatment.
Well, I, of course, can't speak to what the facilities are doing. I did think, and I have not reviewed this in a long time, but I did think that the consumer could choose anyone they want to represent them. And so if the resident chooses to have that person represent them, I think that that may not be a problem, but if they're not competent, then there might be some issues there. I would have to investigate this further to see what I thought the rule was. Any facilities out there or members out there who want to respond with what their current practice is, we can certainly, we have time to look at that now.
Any word on the current emergency order, which expires January 15?
The Michigan emergency order, no, but I do know the governor has an update today at noon, so we'll see where that is.
Okay, it looks like those were the last questions, so I will go ahead and turn it back over to you, Deanna.
Okay, so let's take a few minutes and wait to see if any members want to respond to what they might be doing about vaccine consents. And in the interim, I'd like to end with a short discussion about how you all might be doing overall. We are fully aware that the pandemic continues to be extremely burdensome for members and residents. And all of this has been long and very trying. But it seems that members may have come to some sort of stability during this crisis. We are basing this on the significant decrease in member questions coming in and the reduced number of directives that we're getting from MDHHS and CMS. There's no question that what we do get is more and more complex, complicated, and sometimes often conflicting, but we're not seeing so much happening. And so we kind of assume that when we hear little or nothing from our members, that you're all doing fairly okay. And unless we hear that are continued problems or questions, I just have to figure out what to focus on in our education webinars here, and also it informs our discussion and with the state. So we hope that you continue to let us know where your problems and challenges are, and we will try to address them as best we can. Remember that our discussions with the state, both Laura and MDH, are often based on your input. So as a final piece, Blake, do we have any member comments?
We did get one. Someone said, we took a verbal consent from family members and wrote verbal consent on their vaccine consent form and documented in their chart that we received a verbal consent. We mailed the consents to DPOAs, but did not get very many back before our vaccination day.
Okay, thanks. I think that the issue here, if I understand it, is gaining consents from family members who are not guardians or durable powers of attorney. We can research that, and if so, I'll figure out who asked that question, and we can see how we can follow up.
Oh, okay. Have you heard any discussions about what happens after a facility is vaccinated, other than reducing the risk of becoming infected? Should we anticipate changes in visitation, communal dining, activities, etc.?
My understanding through discussion with the state is that they don't anticipate any major changes for several months, maybe even into early summer. And they're going to base these decisions on the transmission rates, the positivity rates. They're not going to base it on the fact that maybe all of your residents are vaccinated. They're going to look at the outcomes and will change their guidance according to that.
Since the orders are not changing regularly, things have stabilized. I think our next challenge will be once our residents are vaccinated, if there will be changes in the MDHHS orders, which is...
Right. And that's what we just talked about. That certainly would be welcome to see more visitation and fewer restrictions and less complicated and conflicting guidance as well. So we'll have to see how that plays out. But please do let us know any other challenges that you're coming upon out there.
Okay. In Macomb County, we are following the MIOSHA guidance for remote work as much as possible after it being issued October 14th of 2020. MIOSHA says it is in effect for 6 months. We are wondering if we can allow office workers back into the building sooner than April, especially with the vaccinations.
At this point, I would say no. I believe that the intention from the state, the CDC, and definitely MIOSHA is to continue the current practices as they are required. And I don't anticipate that they're going to change these pieces until they see significant changes in the transmission rates, etc. Even though technically, if all of your facilities vaccinated, they should be well protected. But they're not going to change things until they know that. They also really don't know how long the vaccine is going to be effective. They did not have time to test that in order to put get the vaccine on the market. So although they know that it is very effective, they don't really know how long it's going to be effective. So they're going to be looking at data for a long time. And additionally, I want to give you an update. We've been in discussion with MIOSHA through a group that we're working with at the state. And MIOSHA has an awful lot of rules. Let me reframe that. Has some rules that seem to be a little bit more strict than MDHHS or CMS or LAURA for that matter. And mostly that has to do with the use of KN95 masks. We are in the process of these discussions. We're trying to seek clarity because it still seems a little unclear at this point what the requirements actually are. But the MIOSHA, all of the MIOSHA standards are very much still in place. They're going to be in place for a while. And as we get some clarity about use of KN95 masks and some other pieces, we will let you know. Additionally, about remote workers, MIOSHA is not the only requirement for that. MDHHS still in its epidemic orders continues to say that anyone who can effectively work at home should work at home.
Okay. Can we allow animals in our facilities now?
I don't believe so, but it's something that I have not tracked very closely, so we can look at that.
Okay. I don't think summer is appropriate for relaxation of visitor restrictions. We need to push harder for earlier changes. It is inhumane to not allow if vaccines are in place.
Well, and we agree with the fact that we believe that we need more visitation now. We believe that with adequate safeguards, there's no reason why we can't allow visitation in our facilities. Granted, the virus is extremely infectious, but at the same time, there are things that we do to significantly mitigate that risk. We still have concerns, very strong concerns, about the fact that they will not allow, and they continue to not allow, visitation to persons who are at end of life if they're COVID positive. They believe that they've loosened up some of these restrictions, and they have. But you know, even in level E, although it's a little bit more flexible, there's still all of the counties are at level E except for one. So essentially, general visitation is still not allowed, and we have continued to argue for that with the state. To date, they pretty much they acknowledge the fact that it's hard on our residents, but they have not changed their mind about that. And the messages that we get from them continue to be about safeguarding the population until they are sure that transmission is going down. But I want to assure you that we continue with those messages to the state on an ongoing basis.
To answer the pet question, I was on a call with CRC Communities hosted by MDHHS, and the question about animals, pets came up. They said no changes to these restrictions have been made yet, but they would reach out to their upline regarding the request from facilities.
Okay, great. Thank you.
All right. That appears to be the last question. So if anybody thinks of anything after the webinar has concluded, as always, you can fire off an email to Safe and Calm, Deanna, or Dalton at leadingagemi.org, and we will make sure to get those questions answered for you. So at this time, we would like to thank Dalton and Deanna, and we would also like to thank the 85 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Just a quick reminder that we are not holding Safe and Calm webinars on Fridays anymore, so our next Safe and Calm webinar will be next Wednesday, January 20th at 10 a.m. Eastern Standard Time. So we will see you all then, and everyone have a great remainder of their day. Thank you.
Take care, everyone. Bye.